Welcome to the deep dive. Today we're plunging into the really critical world of mental health nursing.
Yeah, it's a complex field.
Definitely. Our source material is, well, it's basically a comprehensive nursing exam guide. So it's packed with these real-world scenarios, expert responses, really shows the sharp end of decision-making.
And that's our mission for this deep dive, isn't it? To really pull out those crucial nuggets of knowledge.
Like that.
It's not just about what nurses do, but digging into the why. Why certain actions are paramount for safety, for the therapeutic connection, for patient well-being overall.
Right. So the goal is to extract the most important facts, maybe some surprising details, those real aha moments. We want you to leave feeling genuinely well-informed about mental health care in practice.
Let's do it.
Okay, so our journey today starts right at that sharp edge, like we said. Those moments where immediate safety, de-escalation, they're everything.
High stakes.
Absolutely. A wrong move can have serious consequences. So nurses rely on very precise, evidence-based actions. Okay, let's unpack this first one. Imagine a mental health worker. They're caring for a client, and the aggressive behavior is clearly escalating. What's the absolute first thing, the sort of foundational principle for safety there?
That's a really key question. Immediate safety is always the number one priority. And the first step, it often sounds simple, but it's incredibly effective. Physical distance.
Physical distance.
Yeah. The sources emphasize maintaining about 4 feet from the client.
4 feet. Okay.
And the insight here, is that this distance, it isn't arbitrary. It's about safety for everyone, client and staff. It creates that vital space needed for de-escalation.
Right.
And crucially, it avoids provoking more confrontation by, getting into their personal space.
That makes sense. That 4-foot distance is not just like avoiding getting hit. It taps into something deeper, doesn't it? Personal space.
Exactly.
Think about how violating someone's bubble in just everyday life can ramp up tension instantly. So a nurse uses that innate reaction, giving space signals respect that de-escalates, says, I'm here to help, not control, kind of without saying a word.
Precisely. It sets a non-threatening tone when emotions are already high.
Okay, so let's take another high-stakes one. A client says they're hearing voices, and these voices are telling them to get a knife and hurt themselves. What's the immediate, the non-negotiable intervention there?
Well, when a client voices intent for self-harm, especially naming a specific method...
Like the knife.
Right, like the knife.
Wow.
The absolute top priority becomes removing access to that means. So the most direct intervention is to accompany the client, make sure they cannot access the kitchen or any sharp objects.
Stay with them.
Stay with them, ensure safety until that hallucination subsides. If we connect this to the bigger picture, it's really about proactive prevention, understanding that the environment itself can be a trigger or make things worse, and that quick action can literally prevent a tragedy.
That proactive bit is so vital. Understanding vulnerabilities, taking decisive action.
Okay, speaking of acute situations, picture this. A client with schizophrenia. They're acutely agitated, pacing, refusing meds.
Okay.
Talking loudly in the hallway, disturbing everyone else. Given all that, the disturbance, the potential escalation, what's the most appropriate nursing action for everyone's safety?
Right, so in these situations, acute agitation, maybe verbal attempts or less restrictive things haven't worked.
They're not enough.
Exactly, they're insufficient. The most appropriate action then becomes transporting the client to a seclusion room.
Seclusion? Okay, that sounds intense.
It does, and this raises an important question. Why seclusion? Sounds very restrictive, and it is, but it's crucial to understand it's not punishment.
Right.
It's seen as a therapeutic intervention, really a last resort. It provides a safe, crucially, a less stimulating environment to help manage that acute agitation.
Okay, less stimulation. Yeah. Ensuring safety for the client, other patients, staff. It's about crisis containment, preventing harm, and giving the client space to regain some control.
Seclusion definitely sounds like it gets immediate safety sorted. But, for someone already struggling, doesn't that risk feeling incredibly isolating? Maybe even traumatizing? How do nurses balance that, make sure it doesn't undermine the therapeutic relationship?
That's a really critical point, and it's absolutely considered. Seclusion, while it's used for that immediate safety, it's never just locking someone away. It's always paired with constant monitoring, frequent checks, clear communication.
So they're not just alone?
No, absolutely not. The nurse explains why it's happening safety, and the moment that agitation starts to subside, the goal is always reintegration. Get them back, resume therapeutic engagement. You minimize the duration and frame it clearly as protective, never punitive.
Okay, that context is important. So what does this all mean when we shift to the nuances of, say, assessment and diagnosis, especially when you've got multiple complex issues cropping up at once?
Right, it gets tricky.
Let's take a scenario. An older homeless client comes into the psychiatric clinic, complaining of chest pain, but they also need a prescription renewal for alprazolam, Xanax.
Okay, so physical and mental health concerns.
Exactly. Faced with both, what's the very first action the nurse has to prioritize?
What's fascinating here and absolutely critical is the immediate prioritization of physical health when potentially life-threatening symptoms are present.
Like chest pain.
Like chest pain, absolutely. The very first action, refer them straight to the cardiology unit. No delay.
Wow. Okay, so before even addressing the Xanax renewal.
Definitely. It's a stark reminder, isn't it? Mental health issues often exist alongside physical ones. A truly holistic approach always starts with immediate physiological needs. You can't effectively treat the mind if the body's in crisis. Basic physical well-being has to be secured first.
That makes perfect sense. First things first, make sure they're medically stable. Okay, building on that idea, foundational assessments. Look at another really complex one, involving a vulnerable person, a mother. Her 8-month-old infant has profound mental and physical disabilities. She tells the nurse she's depressed, really struggling to cope, feels she hasn't hit normal milestones herself.
Oh, that's incredibly tough. Very sensitive.
Deeply sensitive. In that situation, what should the nurse ask first?
Well, in a situation that vulnerable, the immediate concern has to pivot to the safety of both the mother and that infant.
Right.
Both. So the nurse's first question, difficult as it is, must be about harm. Have you ever thought about harming yourself or your child?
Straight to the point.
It has to be. It's a direct assessment of safety, particularly crucial for vulnerable populations like infants. It identifies any acute risk factors for self-harm or harm to others right then and there. It's about rapid risk assessment, protecting the most vulnerable. It's not about judgment.
That really underscores the need for that safety-first lens, even amidst immense emotional pain. Okay, final assessment scenario for this section. A male client experiencing delirium tremens, DTs.
Severe alcohol withdrawal. Very dangerous.
Exactly. Life-threatening. Extreme confusion, tremors, maybe hallucinations. The body's reacting violently to the lack of alcohol. This client is dehydrated and confused. What's a key nursing action for his physiological stability?
Given the dehydration, the confusion, a really critical nursing action is simply ensuring he gets oral fluids.
Just hydration.
Just hydration, but it's crucial. If we connect this to the bigger picture, maintaining hydration is absolutely vital in DTs. It helps prevent severe complications, supports recovery.
Even if they're confused.
Especially if they're confused and may be unable to cooperate fully. Ensuring fluid intake is paramount for survival, for recovery. It's a foundational intervention. Directly impacts brain function, vital organ stability. You have to address that basic need.
All right, let's shift gears. Medication management. And here's where it gets really interesting. This next one highlights something potentially dangerous if you don't know the specifics.
Okay, I'm intrigued.
We have a client taking phenelzine. That's an MAOI.
Monoamine oxidase inhibitor. Yep. Older class of antidepressants. Powerful but tricky.
Right. And they're admitted to the hospital for uncontrolled hypertension. So what's the critical dietary link here? What foods would a nurse tell them absolutely do not touch these?
Yes. MAOIs in diet. What's fascinating here, and critically important, is that link. It can be life-threatening.
Really?
Oh, yes. The nurse has to instruct the client to strictly avoid foods high in tyramine.
Tyramine, okay. What kind of foods are we talking about?
Well, things like aged cheeses, cured meats like pepperoni or salami, fermented foods, certain beers and wines. The sources specifically mention deep-fried shrimp, pepperoni pizza, and beef tips with gravy as examples.
Wow, okay. Pizza, shrimp. Seems common enough.
Exactly. But consuming these tyramine-rich foods while on an MAOI can trigger what's called a hypertensive crisis.
Which is?
A severe sudden spike in blood pressure. It can lead to stroke, heart attack. It's a medical emergency.
Yikes.
Yeah. So this scenario really hammers home the vital role of patient education in medication safety. Seemingly simple dietary choices can have incredibly serious consequences.
It's incredible how intertwined it all is. The everyday choice can become dangerous. Okay, next. An RN is teaching a client about starting abstinence therapy using disulfiram. That's antabuse, right?
That's the one. Used to help people stay off alcohol.
So what's the absolute key piece of information that client must understand before starting this medication?
This raises an important question about patient compliance and just basic understanding of an immediate requirement. It's very specific.
Okay.
For disulfiram, the client absolutely has to understand they need to be completely alcohol-free for a full 12 hours before taking that very first dose.
12 hours minimum. Why is that?
Because disulfiram works by causing a really severe, unpleasant reaction if any alcohol is consumed. We're talking nausea, vomiting, flushing, chest pain, difficulty breathing. It's designed to be a strong deterrent.
So you absolutely don't want that reaction with the first dose.
Exactly. Ensuring the client fully gets the immediate implications, the requirements, before they even take that first pill. It's absolutely key for their safety and for the treatment to even have a chance of working.
That really drives home the importance of thorough patient education. Crucial for compliance and safety. Okay, finally in this section, a client with schizophrenia, admitted to the psych unit, aggressive behavior, auditory hallucinations,
Difficult situation.
and refuses to eat, believes the food is poisoned.
A common delusion, unfortunately, makes nutrition very challenging.
So what intervention should the nurse use here to address that specific delusion and hopefully encourage the client to eat?
Right. This is all about therapeutic communication and building trust, even in the midst of these profound delusions.
How do you do that?
Well, the intervention should be to assure the client, calmly and clearly, that all food served in the hospital is safe to eat.
So you don't argue with the delusion.
No, you don't validate the delusion by arguing about poison, but you directly address the underlying fear. By maintaining a calm, reassuring presence, stating the fact the food is safe, the nurse tries to build a small foundation of trust. It's a crucial step. It might make it possible for the client to eventually feel safe enough to engage with treatment and, importantly, get the nutrition they need.
Okay, so now let's shift focus again. We're looking at strategies that support recovery and, long-term well-being. What stands out to you here in this next set of scenarios?
Well, let's see what we have.
Let's start with an RN providing education. It's about strategies for a safety plan. For a female client who's a victim of intimate partner violence, what kind of specific actionable strategies should be in that plan?
Safety planning for IPV. What's fascinating here and really vital is the specificity needed. It's not just general advice like be careful.
It needs to be concrete.
Absolutely concrete, actionable steps. Things like establishing a code word or signal with family and friends, something that signifies violence is happening or imminent without alerting the abuser directly.
Smart.
Yeah. Having a bag packed and hidden, ready to go, with extra clothes, essential documents, keys, maybe some money, things for herself and any children.
Go bag.
Exactly. And crucially, planning an escape route, maybe more than one. Thinking about how to get out if the abuser blocks the main exit. Window. Back door.
Thinking through the worst case.
Precisely. These detailed, tangible plans dramatically increase safety for the client and their children in incredibly dangerous situations. They empower them with actual tools.
Those specific steps sound absolutely vital for survival. Okay, different angle now. A client with agoraphobia, that's the fear of crowds, open spaces.
Right. Can be debilitating.
They're starting desensitization therapy with a therapist. What's the highest priority nursing action for the RN on the unit to make sure that therapy can even start effectively?
Okay, this raises an important question about the foundation of therapy itself. For any therapeutic intervention, but especially with anxiety disorders like agoraphobia, where the person feels intensely vulnerable, the highest priority nursing action is establishing trust, providing a calm, safe environment.
Trust and safety first.
Absolutely fundamental. Without that foundational sense of safety, that trust in the environment and the staff, effective desensitization, or really any deep therapeutic work, it just isn't possible.
Right.
It's the essential starting point. The client has to feel secure enough to even begin confronting those fears.
That really puts it in perspective. You need that emotional safety net firmly in place before the real work can even start. Okay, our final scenario for today. A homeless client reports feeling sad, depressed, and they've only had about 4 hours of sleep.
Okay, multiple issues there. Homelessness, depression, sleep deprivation.
Yeah. What's the most important action a nurse should take within those first 24 hours after treatment begins?
Well, if we connect this to the bigger picture, it really emphasizes how crucial addressing basic physiological needs is, like sleep. It's fundamental to both mental and physical well-being.
So before tackling the depression directly.
Often, yes. The single most important action in those first 24 hours is often simply to allow the client to rest and sleep.
Just let them sit.
Let them sleep. Before you can effectively implement complex mental health interventions, the body itself needs to be in a state where it can begin to heal, to engage. Severe sleep deprivation. It profoundly impacts mood, thinking, overall health. It makes effective treatment incredibly difficult, maybe even impossible until it's addressed. Basic needs first.
Wow. We have covered such a huge range today, haven't we?
We really have.
From that immediate crisis intervention, the de-escalation tactics, all the way to the nuances of medication management and that deeply empathetic therapeutic communication we just talked about, it really highlights how mental health nursing is this delicate yet incredibly powerful balance. Science, empathy, critical thinking, often under immense pressure.
Absolutely. And I think the core takeaway looking across all these scenarios is that effective mental health care is always truly person-centered at its heart.
Person-centered.
Yeah. It consistently prioritizes safety first and foremost. It seeks to foster understanding, both for the nurse and the client, and ultimately it aims for empowerment, helping people navigate really challenging, vulnerable circumstances.
So what does this all mean for you listening? Well, perhaps it's a deeper appreciation for the incredibly nuanced, complex care that mental health professionals provide every single day. Or maybe it's a new perspective on how even seemingly small, specific actions like ensuring someone gets water or just has a safe room or gets some sleep, how those can have profound impacts on supporting someone's well-being.
And maybe a final thought to leave you with, as you reflect on these scenarios we've discussed, consider this. How does understanding the why behind these specific nursing interventions change your perception of mental health support? Not just in a clinical setting like a hospital, but maybe in your everyday interactions. How might it change how you think about supporting someone around you who might be struggling?